For the second session, I would now take the opportunity to invite our esteemed chairpersons, senior consultant physicians, Dr. Satish Chugh, Dr. Suchin Bajaj, and Dr. Sonika Lamba.
I, along with my two fine colleagues, Professor of Medicine Suchin Bajaj and Sonika Lamba, we welcome the speaker, Dr. Vikas Deswal, regarding this new things, Corona, and its different myriad aspects. Dr. Vikas, please. Dr. Vikas is infectious diseases in the internal medicine. He is a teacher. Medicity, he did his infectious diseases training in prestigious Christian Medical College, Bangalore. Dr. Deswal has a wide experience in the diagnosis of management of infections across various specialties. He has a special interest in managing HIV, tropical fever, dengue, malaria, enteric, scab typhus, and infections in transplant and oncology patients. His other areas of interest include antimicrobial stewardship, management of multi-drug resistance infection and infections in critically ill patients. And he is working probably with the famous now our Dr. Sushila, no? Yes, boss. Sushila Kataria, she is well known to all of us. We are from Rohtak.
Thank you, sir, for that wonderful introduction, and I would like to thank the organizer for giving me an opportunity to talk here. So I would be talking on COVID-19 and diabetes and the role of monoclonal antibodies in treatment and PEP as a role in post-exposure prophylaxis. So these are my necessary disclosures before I move on to my talk. Along with this, I have two more disclosures. One is that I am not an endocrinologist, I am an infectious disease physician, and the second disclosure is that this topic was allotted to me 6 months back, and a lot of water has flown under the river after that, and a lot of evidence, new evidence has come up. So I would put all my presentation in the light of the previous recommendations and the current evidence to support the talk. So this would be the outline of my talk. I would be briefly talking on diabetes mellitus as risk factor for severe COVID-19. I would also be talking about the pre-infection glycemic control and the COVID-19 severity. And the last part of my talk would focus on monoclonal antibodies as a treatment options for mild and moderate COVID-19. So as we all know, there are various comorbidities which are associated with COVID severity, and majorly these are asthma, which puts you at risk of 1.5-fold risk for hospitalization and poor outcomes. Then you have hypertension, which increases the risk by 3 folds. Then you have obesity, which increases the risk by 3 to 4 folds. Diabetes as a whole increases the risk by 3 to 4 folds. If you have a poorly controlled diabetes or a poor glycemic control before the onset of the infection, then the risk increases to even 4 folds in some scenarios. However, the increase in the risk with increase in the HbA1c is not linear, and that we would subsequently discuss in later part of my presentation. Also, the chronic kidney diseases increases the risk of severe COVID-19 by 4 folds, and if you have more than one comorbidities, that is 2 or more comorbidities, then the risk of acquiring a severe COVID-19 increases by 4.5 folds, and if you have 3 or more comorbidities, then the risk goes up 5 times for acquiring a severe disease. So this is just a basic pathophysiology of how hyperglycemia may worsen COVID-19 and its impacts its prognosis. There are two different mechanisms. The SARS-CoV-2 infection can directly affect on the beta cells, and because of that action on beta cell, there is decreased insulin secretion. On the other hand, when you have a severe disease in the second week of illness, there is cytokine storm. Because of this cytokine storm, this leads to development of insulin resistance. Put together these two mechanisms of decreased insulin secretion and increased insulin resistance, this leads to hyperglycemia. And because of this hyperglycemia, there is endothelial dysfunction and platelet activation. Because of these two mechanisms, there is thrombosis and subsequently leads to development of multi-organ failure, which is the hallmark of and the reason for the poor outcomes in the second week of illness in the COVID-19 patients. Now let's look at some of the studies which looked at diabetes as a risk factor for severe disease. This was a large observational studies meta-analysis which included 83 studies, and it had more than 78,000 patients included in this study. This study came up very early into the COVID pandemic, and this was published somewhere in August or September 2020. In this study, they found that the pre-existing diabetes was associated with almost twofold higher risk of having a severe or critical COVID-19 illness, and almost threefold increased risk of in-hospital mortality. So, very significant higher risk of hospitalization as well as mortality was associated with diabetes as a pre-existing comorbidity. And then coming to this study, this was published in Lancet last year, and this looked at a large population of COVID-19 patients who were admitted to the hospital in England. And in this study, they found that those patients who had type 1 diabetes, they were at maximum risk of acquiring the severe form of disease or progressing on to death in that subset of patients. The second high risk was that those patients who had type 2 diabetes mellitus, and those patients who had no diabetes, the risk of acquiring a severe disease was much lower compared to those patients who had type 1 or type 2 diabetes. Results from this same study, they found that the adjusted odds ratio for in-hospital COVID-19 related deaths were 3.5-fold increase in people with type 1 diabetes and 2-fold increase in people with type 2 diabetes. So it is very clear that diabetes is a significant risk factor for severe disease. Now this is another study, very interesting study, which came from Sweden, and this was published in Lancet Regional Medicine. In this study, they looked at the incidence of per 1,000 person years for mortality in COVID-19 patients who were suffering from diabetes as a pre-existing comorbidities. They stratified their population into type 1 and type 2 diabetes, and they found that the rates of hospitalization, the rates of ICU admission, and the death rates were significantly higher in both the subset of patient, be it type 1 diabetes or type 2 diabetes. However, there was some contrasting data which emerged from this study. In this study, the type 2 diabetes patient actually performed poorly with respect to all the things like hospitalization, ICU admission, or death, compared to the previous study in which the type 1 diabetes patients actually performed worse than the type 2 diabetes patients. Now, by now it is fairly clear that the diabetes is a significant risk factor which is associated with severe COVID-19. Now let's look at whether pre-infection glycemic control affects the disease severity or not. To answer this question, I looked at this study, and in this study they found that as the HbA1c goes on increasing from 6 to up to 10, there is a linear relationship between the disease severity. However, once the HbA1c is about 12, it sort of there is no further increase in the risk for acquiring a severe disease, and it sort of plateaus. Below part of the graph is the magnified version of the HbA1c levels between 6 to 9. In this range of HbA1c from 6 to 9, there is a sort of a linear relationship, and as the HbA1c is increasing, the risk of acquiring severe disease with COVID is also increasing. So by now we are fairly clear that diabetes and poor glycemic control both are risk factor for severe disease. Now, what are the treatment options for mild COVID? And since my talk was basically to focus on the anti-SARS-CoV-2 antibody products, these are some of the anti-SARS-CoV-2 antibody products which are available in the world. The first one is the most famous one, the casirivimab plus imdevimab, also known as the Regencov, also known as the cocktail or the Trump antibody. The second one is bamlanivimab plus etesivimab. Third one is bebtelovimab, which is the new kid on the block. And then sotrovimab, which is also available. Then tixagevimab and silgavimab, and finally the convalescent plasma. So let's first look at the most commonly used antibody, which was the first one to be available. It is the casirivimab plus imdevimab. These are two distinct antibodies, and they bind non-competitively to the COVID-19 virus cell surface, and they prevent the virus from entering into the healthy cells. And these two antibodies basically were used as a cocktail to prevent the development of the resistance, but that actually did not happen, and subsequently in the various mutated strains of virus like Omicron and the sublineage of the Omicron now, which is BA2, which is the most predominant variant now, is also resistant to this antibody. So this was the first seminal paper which came up, which led to the US FDA approval for this molecule, and in this study, they studied casirivimab plus imdevimab versus placebo in outpatients with COVID-19. This was a double-blind phase 3 RCT in outpatient with mild to moderate COVID-19. And in this study, they had actually studied 2 doses of casirivimab plus imdevimab, 600 and 1200 milligram. The inclusion criteria were in onset of COVID-19 symptoms less than 7 days from randomization, SARS-CoV-2 PCR positive at baseline, and criteria and more than one risk factor for severe COVID-19. The endpoint for this study was proportion of participants with COVID-19 related hospitalization or all-cause death through day 29. In this study, they found that there was 70 and 71% relative reduction in the COVID-19 related hospitalization of all-cause deaths in participants who received both 1200 and 2400 milligram doses. So there was no benefit of an incremental dose of 2400 milligram, and based on this, they selected the dose of 1200 milligram to be used in this cocktail therapy. And they also found that the symptom resolution in both the casirivimab and imdevimab groups were 4 days earlier than the placebo group. In the hospitalized patients, they also found that there was a reduction in the proportion of those patients needing ICU care, and they were discharged earlier compared to the placebo group. Now, this was the evidence for this molecule as a outpatient therapy. Now, let's look at this molecule as an hospitalized patient, and this question was answered from the evidence generated by the recovery trial. And this they studied this molecule casirivimab plus imdevimab in hospitalized patient with moderate to severe disease, and it was a randomized controlled open label platform trial. They randomly allocated to either usual standard of care alone or usual care plus high dose monoclonal antibodies of casirivimab plus imdevimab. In this study, they used a dose of 4 gram for each casirivimab plus imdevimab, whereas in the previous study for outpatient population, they had used only 600 milligram. And also to note in this study was that 94% of the patients in this study were also receiving systemic steroids. Before going into the results, they actually had stratified this study population into 2 different groups. One was the seronegative group, that is those who had antibodies negative at the baseline, and the second was the seropositive group, that is those who had antibodies positive at baseline. In this study, the results were very interesting, and they found that there was 24% mortality in the casirivimab plus imdevimab arm, whereas 30% mortality in the placebo arm in the seronegative subgroup at baseline. And this led to a 6% absolute risk reduction in terms of mortality and 20% relative risk reduction in terms of mortality, which was a very significant number in terms of absolute reduction in mortality. However, when you look at the overall population and the seropositive population, there was no difference in terms of outcome with respect to mortality, and the outcomes were very similar in the 2 groups. So it is important to understand here is that this molecule needs to be used only in a seronegative individual who is hospitalized for moderate to severe disease, and the dosing also is pretty high in that setting, and you need to give 4 grams each of casirivimab plus imdevimab compared to 600 which was used for an outpatient setting. Now let's look at the evidence which is available for its use as a post-exposure prophylaxis. And this study looked at use of subcutaneous REGEN-COV antibody combination for COVID-19 prevention in individuals at high risk of contracting SARS-CoV-2 in households with documented infections. In this study, they included patients who were asymptomatic healthy individuals more than 12 years of age, and they were within 96 hours of a household contact being diagnosed with SARS-CoV-2, and they randomized 1:1 to receive 1200 milligram of REGEN-COV or placebo via subcutaneous injection. The primary efficacy outcome for this study was the proportion of participants without evidence of infection or prior immunity who subsequently developed symptomatic SARS-CoV-2 infection during a 20-day efficacy assessment period. In this study, they found that in the placebo arm, 59 out of 752 patients, that is 7.8% of the patients in this placebo group had developed an infection at day 28, whereas in the REGEN-COV arm, it was only 1.5%, and this led to a relative risk reduction of 81%. However, all that glitters is actually not gold, and then came this new variant, and with first reports of Omicron being emerging from South Africa and Botswana in 3rd week of November, which actually led WHO to label it as a variant of concern and named it as Omicron. This actually was associated with significant immune evasion because of a large number of mutation. at least 30 different mutations were present in the anti-spike protein itself, which is actually the target site for most of these monoclonal antibodies and the vaccines which are available to us. So let's look at how these antibodies perform when you have dealing with an Omicron variant. And this was a very nice study of basic sciences which was published in the Journal of Cell. And they looked at the performance of various antibodies against the Delta variant, which is depicted in the green, and the Omicron, which is depicted in purple. So first let's look at casirivimab. It performed well in Delta variant, did not perform well in Omicron. Then imdevimab had no activity against Omicron, and then when they combine it also, the activity against Omicron was very little. Similarly, for other antibodies like bamlanivimab, etesevimab, and the bamlanivimab-etesevimab combination, the activity for Omicron was very little, almost negligible, even at very high doses. Compared to sotrovimab, which is also one of the monoclonal antibodies which is not yet available in India, this had very good activity against both Delta and Omicron. But the problem with this antibody is that the sublineage of Omicron, that is BA2 sublineage, it has very little activity. And that BA2 sublineage actually is the most common infecting lineage these days of Omicron. So this is the data from INSACOG. This is a very nice graph which clearly shows that when the Omicron came to India, and after somewhere after December, third week, almost all the cases of COVID-19 were due to Omicron variant, and this actually has replaced Delta completely, and there are only 4 to 5% of cases of current infection due to Delta, and 96 to 97% cases are due to Omicron, and that too BA2 sublineage instead of BA1 sublineage. And based on this, actually, the region COV came out with a statement that it should not be used in areas where there are high prevalence of Omicron as the infecting agent. And subsequently, FDA also said the same thing. These are some of the other antibodies. I just quickly go on to them. This is FDA. This also has a emergency use authorization from FDA for outpatient treatment of COVID. This is active against alpha. As I said earlier, this is not active against BA2 sublineage of Omicron. And BA2 sublineage is actually the predominant sublineage of Omicron currently. This is given as 500 milligram single infusion, not available in India. Now, the important one now is the bebtelovimab. This also has an emergency use authorization. This has activity against Omicron, including the BA2 variant. This is approved for use in non-hospitalized patients who have risk factors for progression to severe disease. And the problem with this is that the data so far has not been published. It is only available in medRxiv, and it is also not available in India. Then tixagevimab and cilgavimab. This is the only monoclonal antibody which is approved for pre-exposure prophylaxis. This should be used in patients with moderate to severely immunocompromised and who have an inadequate immune response to COVID vaccination. This is also again not available in India, the only antibody cocktail which is for pre-exposure prophylaxis. The last one is the high titer convalescent plasma. There are multiple trials which have very contrasting results, but of late FDA has approved for mild COVID with risk factor for severe disease based on this trial which was published in NEGM, and they found that the convalescent plasma performed much better in terms of mortality compared to the control group, and there was 2.9% mortality in the plasma group and 6.3% in the control group. The problems with convalescent plasma are that you need to have a COVID variant specific plasma. You cannot use a Delta plasma for a Omicron plasma. So that is one problem. So we need to screen for a lot of things when we are using plasma, and there is contradictory data from multiple other studies. It has not been studied for Omicron variant and is not recommended in hospitalized or immunosuppressed patients. To sum it up, diabetes and poor glycemic control are risk factors for severe disease. SARS-CoV-2 emerging variants are a concern, and our therapeutics needs to evolve simultaneously with the emerging variants. Monoclonal antibodies present a treatment option for COVID based on the activity against specific variant, and therapeutics needs to evolve along with the emerging variants. Thank you.
I have a small question from you. And these clonal antibodies, they became famous after Trump got the disease. And to be very exact, these antibodies, they should be infused in the first 72 to 120 hours. And yours is a tertiary level hospital. How much of your patients were able to get that service within that time frame?
Sir, if we looked at the inclusion criteria of these trials which I had discussed, they had included patients up to, in one of the trial it was day 7, and in the hospitalized patient it was day 9. So the FDA, when they gave the recommendation for use in terms of emergency use authorization, they had given that ideally it should be used within first 7 days of illness. The sooner the better.
Okay.
And sir, a very nice lecture. Which of the monoclonal antibodies are available in India apart from
So
Kasari?
at the moment there is only this casarivimab plus
Yeah.
imdevimab is available in India by the name of Regencov. The
And
others are in pipeline. Very soon they would come to India.
And the
Bebtelovimab is the one.
cost of the therapy?
So casarivimab plus imdevimab actually comes as a 1200 milligram plus 1200 milligram injection. So you need to have 2 patients simultaneously to give it. And the cost of 1200 milligram plus 1200 milligram is 1,20,000. So for one patient, if when you would be using 600 plus 600, it would be 60,000. That is the published price, but
Right.
Thank you very much, sir, for a
Thank you, sir.
wonderful talk. Brought back the memories of the last year dark times that we all faced, I think. We had a lot of experience running the plasma bank for the Delhi government. We were the ones who operated the plasma bank entirely from setting it up till the time it was closed down. When the surprisingly enough, just as the antibody came into India, WHO had this recommendation that plasma is no longer useful. Although anecdotally we saw a lot of good results, as well as LNJP did a large study of 400 patients, and then Mayo Clinic also brought out a study saying that if given in time and if the antibody levels were adequate, plasma was very useful if given in early stage, which is exactly what monoclonal antibodies also do. So what was your opinion, because you also did a lot of work with plasma last year, so what was your experience in the two?
so the problem with plasmas are one that we are not aware of the titer of that plasma. The quality of that plasma is a
Can I break in? So at ILBS, the
Yes, sir.
plasma bank that we did, we always issued only plasma after checking for neutralizing antibody levels. So there was no plasma issued from that particular plasma bank without checking for neutralizing antibodies, which was unfortunately not the case with most other plasma banks.
Absolutely, sir. So the first problem was, other than the ILBS plasma bank and few others, the majority of the plasma banks which they were issuing, the titers were not checked, and we were actually not aware of the quality of the that plasma. Second was the issue with the patient selection. So I have seen many of the patients or many of the physicians prescribing it very late into the illness. So these are like ready-made antibodies. These are like reinforcements which should be given as soon as possible in the illness. So I don't see a benefit of using a plasma beyond day 5, day 7. Actually, the trial which came up and which sir is also mentioning, actually had said that you need to give within 72 hours of the diagnosis. So it should be given as early as possible. The window for giving the plasma is even narrower than giving using the monoclonal antibodies. So patient selection and the plasma selection is very, very important when we are using convalescent plasma. We also were part of the PLACID trial which was conducted by the ICMR. Unfortunately, the problem with that trial was that if you look at the mean time of giving plasma in that trial was 9 days, which I feel is very late. Some of the patients actually got it on day 17 also. So there's no point of giving plasma on day 17. So that is the problem. The plasma needs to be given as early as possible, and it needs to be high titer, and the patient selection needs to be very carefully selected.
Absolutely, I agree with you. Just
And-
adding to sir's point a little bit. So, actually, awareness is very important. Last year, as I said, So we were managing the plasma bank. We were actually getting calls at 3 o'clock in the night from patient relatives saying patient is on ventilator and doctor is saying arrange plasma immediately, otherwise he will not survive the night. It was so depressing that even qualified doctors who were manning ICUs in large hospitals were giving out statements like this. I mean, there was no use for plasma at all at that time, right?
So basically, the second week of illness, once the cytokine storm sets in, there is no benefit because it is the immune-mediated, immune dysregulation phenomena rather than the virus itself causing the problem. So virus itself will cause the problem in the first week, but the second week of illness is the immune dysregulation. That time the anti-inflammatory agents like steroids and TOSI would perform better than plasma. So plasma has actually no role when somebody is already on ventilator.
So topic is closed. Please, for your time, short your time. Dr. Sonika.
For a very
please.
wonderful discussion.